Your expert is Elizabeth A. Murray, an award-winning professor and forensic anthropologist. She primarily teaches graduate-level gross anatomy for future healthcare professionals. She has also served as an instructor for several professional organizations, including the National Institute of Justice and the International Association of Coroners and Medical Examiners.
Hello. Some of you may recognize me from my previous Great Courses series about forensic science. And you may be asking yourself, what is she doing in a course about musculoskeletal anatomy? But in my role as a forensic anthropologist, anatomy is my primary tool, especially the anatomy of the skeleton. Plus, given that forensic anthropology cases are by and large fairly rare in the day-to-day operations of a coroner's or medical examiner's office, I teach for a living. And while I do teach forensic science, my primary area of teaching is human anatomy. I offer a human gross anatomy course to graduate students studying to become physician assistants and to doctoral students in physical therapy. So after teaching gross anatomy for nearly 30 years now and dissecting hundreds of cadavers, I can say that I'm probably as comfortable with the dead as I am with the living. In fact, some days I prefer my quiet time with the deceased. I also teach a couple of different courses in anatomy for undergraduates. One of them is solely devoted to musculoskeletal anatomy, which is what we'll be focusing on in this course. All of this not only makes for a great career, teaching interesting subjects, but it also allows me to help students understand more about their own bodies, how they enable our routine activities, and the ways in which disease, disorder, and injury can all take a toll. In addition to all the factual information you'll learn, another thing I'd like you to take away from this course is just how remarkable your body is. In many ways, the body is really so durable, but it is also so detailed as to seem almost fragile. Even after all my years of teaching, I still find myself in awe at the complexity of the human body. And I love having my students discover that for themselves, maybe for the first time. That's one thing I hope this course on gross anatomy and movement will give you, a greater appreciation of your body, how it works, and maybe even how you can take better care of it. So what is gross anatomy? I can tell you that it can often be gross in the typical use of that term, especially during dissection or in the morgue. But gross anatomy refers to the structures that we can see with the naked or unaided eye. So this course will not focus on cells and other microscopic components of human anatomy. Instead, we'll focus on bones, muscles, and nerves. In addition, we'll cover the physiology of movement to better understand the relationships of structure and function, such as at the joints of the body. Another thing makes gross anatomy different from typical anatomy and physiology courses. Gross anatomy uses a regional approach, and that's what we'll primarily do here. If you've had anatomy and physiology before, you probably studied it by systems: the skeletal system, nervous system, digestive system, reproductive system, and so on. But gross anatomy examines a particular region of the body, such as the back, thigh, abdomen, hand, that sort of thing. And as we do, we integrate the bones, muscles, nerves, blood vessels, and other structures or organs in that given body region. So in this sense, gross anatomy is far more integrative as compared to systemic anatomy, in which body systems are covered but not usually combined as a whole within a body region. With that said, ultimately, gross anatomy does require the region studied to be put together for a full understanding of the body relationships. This includes the interactions between regions and the overall pathways of structures that travel from one region to another, like blood vessel or nerve pathways. but the regions are studied first. So when we first talk about a blood vessel in a given area, and my students want to understand where that vessel comes from and where it goes to in the body, I tell them, let's leave that in the black box for a while. Or as I'm most fond of saying, you can't eat a pizza all in one bite. So we study regionally like pieces of a puzzle, and my students may not fully understand the connections between body regions until we bridge those areas together later after studying both. In other words, studying the upper limb and studying the chest requires us to ultimately connect the two, particularly when structures like nerves and vessels span those regions. In so doing, we often see name changes as the structures pass a given anatomical landmark or after they give off a particular branch, somewhat like street names may change when traveling from one part of town to another. And as with any field of study, we'll need to learn some terminology. We'll start with some general terms in this lesson and then continue to build on that vocabulary throughout the course. And while many people think of terminology as somewhat dry or boring, I generally don't seem to find that with my students when we're studying anatomy. Learning anatomical terminology is quite literally learning more about ourselves. And in combination with other medical terminology, makes us more informed patients, caregivers, workout partners, and sports enthusiasts. This is true whether you're an armchair quarterback listening to an announcer talk about an injured player or an active participant in softball, golf, dancing, bowling, or yoga. And while I don't want to set the bar too high for myself, while anatomical terminology does require some memorization, that doesn't mean the subject is automatically boring. I once had a colleague, a physiologist by training, who also taught undergraduate anatomy and physiology. We had several sections of students, biology majors, nursing majors, and others, and they were all divided between us. Once, when we were talking about the course, she told me that the bones and muscles were the least interesting part for her. She really didn't like teaching it, and her students didn't like learning it because it was, and I quote, nothing but a bunch of memorization. I laughed and said, if that's how you feel about it, then you're not teaching it right. No wonder your students are bored. For example, I have my students stand on lab benches and do pose downs, while other students describe what actions are happening at what joints and what muscles are being used. They label muscles and bony landmarks on photos of bodybuilders and dancers, and they dissect human and non-human organs to better understand the anatomy. I'd like to encourage you to do some of the same. Maybe not the dissection part, but looking at photos of bodybuilders and dancers, and looking at your own body too, so that what you learn here is more meaningful to you and is actually fun. Another tool we specifically use in my musculoskeletal anatomy course is palpation, to examine by touch. So on certain days, the students sit or lay on the lab benches and use their hands to find certain not too personal bones and muscles on each other. Most are going into healthcare fields and will need to learn to do that kind of hands-on work with their patients anyway. In some cases, you can palpate these structures on yourself, depending on their location. So I'll be encouraging you to use your own body or that of a partner to explore and better understand the musculoskeletal anatomy we'll study. Compared to looking at pictures, it's so much more realistic to actually feel body features and really appreciate that the structures we're learning about are all inside us. So I really encourage you to participate with me as best you can. When possible, musculoskeletal anatomy is best studied in action. Speaking of which, let's start with getting ourselves into standard anatomical position. So if you're not way too comfortable, why don't you stand with me? If you mirror me, you're standing in what's referred to as anatomical position. Now you might say, well, you're just standing there facing forward with your feet slightly apart and your palms facing front. And I'd say you're absolutely correct. That's pretty much the definition of standard anatomical position. And like other standards, the beauty of this is that it universally fixes the body in space to provide a common frame of reference regardless of the various positions we can get ourselves into. This anatomical position allows us to apply directional terms that never change, whether we're standing up, lying down, or even standing on our heads, which I cannot do for you. This position becomes a reference point that is universal, as we'll see. The importance of the palms facing forward was decided somewhere long ago in the study of anatomy. In this position, the two bones of the forearm, the radius and ulna, are parallel from elbow to wrist. When we turn our palms to face backward, the radius crosses over the ulna like an X. You can feel this if you put your hand around your opposite forearm and rotate that palm, a movement which, by the way, happens at the elbow, not at the wrist. We'll learn more about the bones of the upper limb later, but from the standard position, anatomy uses specific terms to express body directionality. For example, superior means up, away from the pull of gravity. So in humans, that's the head end. Inferior means down, towards the pull of gravity, or towards the ground, as I stand here in anatomical position. Anterior means forward, or in the direction that I move, while posterior means backward, or opposite the direction of my typical movement. Now, did you notice that those four terms, superior, inferior, anterior, and posterior, all relate to the space around us in which we navigate? We also have equivalent directional terms that relate to parts of the body. Cranial, or cephalic in some references, means the head end, and caudal means toward the tail end. So, considering that, which of the four terms, superior, inferior, anterior, or posterior, is equivalent to cranial? That's right, superior. Which body term means the same thing as inferior? That's caudal. And while you might say, well, I don't have a tail, you did as an embryo. What's more, cranial and caudal are usually used to refer to the head and trunk of the body. Of course, you're not an elephant, but I think you know where your trunk is. We'll have other terms of directionality to use for the limbs. So in a human, superior and cranial are interchangeable, and inferior and caudal mean the same thing. How about anterior and posterior? We also have body part terms that are equivalent to them. Have you heard of dorsal and ventral? You've probably heard of dorsal related to the dorsal fin on a shark. The dorsal side is the spine side in animals with a backbone. So with regard to anterior or posterior, the anatomical equivalent of dorsal is posterior. Since posterior means opposite the direction of movement, its body part equivalent is the dorsal side of the body. And anterior is the same as the ventral side of the human body. That's the direction in which we typically navigate. Now, here's a pet peeve of mine. The front of the body is not the stomach. The stomach is a food-holding digestive organ inside the body. When I hear someone say something like, wow, she's really looking pregnant, her stomach is so big, I'm tempted to say, what happened? Did she eat that baby? But most people would not appreciate that. The ventral side of the torso can also be called the belly side. Now, most people think belly is just a cutesy little word that might refer to a baby's juicy little belly, but it's a perfectly adequate anatomical term for the side of the body opposite the spine. So in humans, ventral equals anterior, but ventral relates to the body itself, while anterior means in the direction an animal moves. So, as an aside, and you'll see I'm quite fond of those, if anterior means in the direction of movement, does anterior equal ventral in your dog or cat? Nope. Anterior equals cranial in a four-legged creature, since its head is in the same direction in which it moves. Posterior then equals caudal, your dog or cat's tail end. So what is the equivalent of ventral in a dog? If you said inferior, you're right. Dorsal, as the spine side, would be superior in a four-legged animal. That helps to reinforce that superior, inferior, anterior, and posterior refer to the space around us, while cranial, caudal, dorsal, and ventral relate to parts of the body itself. Other anatomical terms we need for the course include medial and lateral. Medial means closer to the midline of the body, and lateral means toward the side of the body. So when comparing the clavicle to the shoulder, which is lateral? If you said shoulder, you're correct. In that comparison, the clavicle is also said to be medial to the shoulder. The terms switch depending on the question asked. But what if I compare the clavicle to the sternum? Then the clavicle is lateral and the sternum is medial. The relationships change depending on which two structures are being compared. In fact, the sternum could be said to be median, which means being on the midline of the body. But other than median structures, since there's only one midline, it's all about comparison. You could never simply say the clavicle is medial, because that would beg the question, medial to what? These directional terms are used to compare structures to each other, and the relationships change depending on what's being compared. Now, to make sure you understand, let's consider an example of three people of different heights. Mary is 5 feet tall, Sam is 5.5 feet tall, and Paul is 6 feet tall. When comparing Mary to Sam, Sam is taller, but when you compare Sam to Paul, now Sam is shorter by comparison to Paul. So just as Sam can be both taller and shorter depending on whom we're comparing him to, anatomical terms can change for a given structure depending on what other structure it's being compared with. To reiterate, lateral means farther away from the midline of the body, medial means closer to the midline of the body, and median means right on the midline. But wait, there's more. The term intermediate can be used to indicate something is between two structures. So back to our example about the sternum, clavicle, and shoulder. You could say that the clavicle is intermediate when compared to the sternum and shoulder, just as Sam was intermediate in height. Two other terms related to the sides of the body are ipsilateral, which means on the same side of the body, and contralateral, which means on opposite sides of the body. We'll occasionally use these terms when talking about body movements, like when a muscle on the right side of the body causes movement to the left. For example, you can see under my skin that as my right sternocleidomastoid muscle contracts, it turns my face toward the left. Therefore, the sternocleidomastoid muscle is said to have contralateral action. There's another instance in which intermediate comes in handy. That is when talking about depths in the body. Superficial means closer to the body's surface. Deep means farther from the body's surface. And intermediate could refer to a structure between those. So if we compare the skin to the muscles, the skin is superficial and the muscles are deep. But if we compare the muscles to the muscles become superficial and the bones are deep. If we compare all three of those, the skin is superficial, the muscles intermediate, and the bones are deep. Now, superficial doesn't necessarily mean right on the body's surface. It just means closer to the body's surface when compared to something else. Also, those terms relate in some degree to how we approach a body, in the lab or perhaps in a physical exam or during surgery. It's as if the body has a cylindrical core down its middle. If the body is face up, which in forensics and anatomy we call supine, the sternum is superficial and the heart is deep to that. If the body is face down, or prone as we say, the ribs would be superficial and the kidneys would be deep to them. And really, that's the only anatomical directional term that varies in terms of body position. In other words, you'd never say that the sternum is superficial to the heart and the heart is superficial to the spine, since the spine is so deep into the body and is more associated with the dorsal aspect. You'd say that the heart is anterior to the spine, meaning it's in front of the spine. Now, some of this you just have to learn by convention. It's not always intuitive. Now, remember that I mentioned that we have some particular directional terms that relate more so to the limbs. Those terms are proximal and distal. Proximal means closer to the origin of a structure, like a limb, while distal means farther away from the structure's origin. So when comparing the shoulder to the elbow, the shoulder is proximal and the elbow is distal. But when comparing the elbow to the wrist, now the elbow becomes proximal and the wrist is distal to it. And again, we only use those terms to compare two structures. So the statement the elbow is proximal doesn't make any sense. Proximal to what? I guess you could say that the shoulder is the most proximal part of the upper limb, but even then the comparison is understood. It's essentially being compared to the rest of the limb. I should add that occasionally proximal and distal are used to refer to other structures. For instance, the proximal end of the small intestine is the region nearest the stomach because that's where the small intestine originates. And the distal portion of the small intestine would be closer to the large intestine, which is where the small intestine terminates. So when referencing a limb, we don't use superior and inferior. We use proximal and distal. With that said, medial and lateral still apply. So if I'm in standard anatomical position, my thumb is lateral, which remember means farther from the midline, and my little finger is medial. Now, what if I turn my hands so the palm is facing backward? What's the relationship of my thumb and my little finger now? Trick question alert. Remember that anatomical position fixes us in space. So even with my palm facing backward, my thumb is still lateral and my little finger is still medial because anatomical position provides a universal standard reference. It doesn't matter what pose we strike. Medial and lateral don't change. That's the beauty of anatomical position. And who decided all this? Anatomical language, like the terminology belonging to all other bodies of knowledge, is a human construct. All these things were decided and settled on hundreds of years ago by groups of learned men who created, debated, and settled on the terms. And in those days, they really were all men. The creation of specific anatomical terminology has a history that dates back at least to the Roman Empire, when some of the oldest known anatomical treatises were formally laid down. In the 2nd and 3rd centuries, the Greek scholar Galen of Pergamon, in what's now Turkey, wrote some of the earliest books providing anatomical terminology. Vesalius from Belgium is likely the most famous anatomist and wrote a series of 7 volumes in the mid-16th century, accompanied by amazing illustrations from his own anatomical dissections. That began a period of time in which most of the muscles, nerves, and blood vessels were identified and named, starting with Vesalius, but taken up by others in France and Switzerland. In 1895, one of the early attempts at standardization was the Basel Nomina Anatomica, proposed at a meeting of German anatomists in Switzerland as an attempt at systematic and international terminology. They laid out some ground rules that set the stage for the terms we still use today. First, all terms had to be in grammatically correct Latin, and would have standard Latin derivations for related structures. For example, given the radius is one of the forearm bones, related structures would contain derivations like radialis. And there's what I call the rule of adjectives, which is extremely helpful to the study of anatomy. If there's a major, there will be a minor. If there's a longus, there will be a brevis. If there's a radialis, there will be an ulnaris for the other bone of the forearm, the ulna. Another convention was that each structure would have only one name, except for cases in which an eponym, a term named after a person, also applied. So there would be a Latin name with an anatomical basis, but the eponym was retained as a second name to honor the so-called discoverer of the structure. Like fallopian tube. Yes, Fallopius was a guy, and so was Eustachius of the Eustachian tube. One thing of note, though, is that all of this, from Galen on, including the eponyms, had and really still has a Western bias. The terminology that came from these meetings of learned men gave no credit at all to others, such as Maimonides, who was a Jewish physician that worked in North Africa, Avicenna from the Islamic tradition in the Middle East, or anyone from Eastern medicine, which has its own extremely long history. In 1955, after 60 years of use, revision, and debate, the revised Nomina Anatomica was approved at a meeting of the International Congress of Anatomists in Paris. It was the standard until 1998 with the publication of the new and improved Terminologia Anatomica that includes both Latin and English terms. And these are just the highlights in the history of anatomical language. There were other revisions and additions between these major milestones. Additionally, because many Asian countries use their native languages in the instruction of anatomy and other sciences, versions in Asian languages largely paralleled the evolution of the Latin anatomical terminology. Other branches of medicine, such as veterinary science, also followed similar courses of standardizing their own anatomical and medical terms. So, how did scientists advance our understanding of these anatomical structures? They did it largely through dissection. And in another lesson, I'll talk more about the history of anatomical dissection. And though we still dissect the body today to aid our understanding, medical imaging techniques like CT scans and MRIs have revolutionized the ways in which we can visualize and study the body. Now, let's discuss some other terms that we'll need to better make sense of the body planes and types of surfaces created, whether by dissection or by high-tech medical imaging. From the standard anatomical position, a vertical cut that divides the body into right and left halves creates what's called a sagittal plane. If the cut is directly on the midline, it's called a mid-sagittal plane. But if laterally off the midline, it can be called a parasagittal plane. Individual organs or regions, such as a lung or a knee, can also have their own mid-sagittal plane. A vertical cut that divides the body or a region into an anterior and posterior portion is known as a coronal plane, sometimes called a frontal plane, which separates the front from the back. Dividing the body or one of its structures into superior and inferior regions creates what's known as a horizontal plane, sometimes called a transverse plane. An organ like the brain looks very different when it's viewed in a sagittal plane, coronal plane, and a horizontal plane. Body parts or organs can also be sectioned in an oblique plane. Notice that these terms require an understanding of the directional terms we covered earlier, such as lateral, anterior, posterior, and superior. Since these foundational terms are so important to the rest of this course, let's end this lesson with a short review and use some amazing technology to do so. Now, here and there through this lesson, we've caught some glimpses of an amazing 3D anatomy table called Anatomage. In lessons 12, 18, and 24, which focus on reviewing what we've learned in each section, we'll be using this Anatomage table more intensely. I've purposely grouped these intensive reviews into just a few lectures because, well, frankly, some viewers might be a bit squeamish about what we'll be seeing there. We'll be taking off the skin of the human body and seeing some very detailed imagery of a human cadaver. So if you like gross anatomy, but you're grossed out by lifelike cadaver images, you can always skip those lessons. Also, you might want to wait on those lessons for a different time if you have young children in the room. All that being said, let's use the Anatomage table here to do our review. Now, how would you describe the relationship between the eyes and the bridge of the nose? The eyes are what compared to the bridge of the nose? If you said the eyes are lateral to the bridge of the nose, that's correct. Now, how about comparing the eyes to the ears? What do you think? The ears are lateral to the eyes. But I guess you could also say the eyes are anterior to the ears, but not directly in front of them. So in anatomy, we can even combine terms to say the eyes are anteromedial to the ears. How do you like that? So the cadaver is in a belly-up position. We call that supine. But if we turn him over, now the body is prone. Prone is face down. And when we look at this surface of the body, we're looking at his posterior surface, or you could also call it dorsal because of the presence of the spine. When we come back to anterior, we could also refer to that as the ventral side of the body. With regard to the superior and inferior aspects, we use those designations for the torso. So the head is said to be superior or cranial, and you can also use cephalic. Whereas the inferior region of the torso we could call caudal as well as inferior. In terms of proximal and distal, remember we use those for limbs. So what if we compare the elbow to the wrist? The elbow is proximal, the wrist is distal. But if we compare the wrist to the fingers, now the wrist becomes proximal and the fingers are distal. What if we want to talk about superficial and deep? The skin is the surface of the body, so it's most superficial. But if we remove the skin, now we're deep. So the muscles would be intermediate to the skin and the bones. We can also use medial and lateral on the surface or on the interior of the body. So the sternum is midline, so we'd say that is medial, whereas the clavicle is lateral to the sternum. If we want to compare the clavicle to the humerus or bone of the upper arm, now the clavicle becomes medial when compared to the humerus of the upper arm. So let's ask you a few quiz questions here. When I'm talking about this skull, is that superior, inferior, medial, lateral? If you said superior or cranial, you're correct. When we look at the spine, that is midline. So how would you describe that when compared to the 12th rib? Right, the spine is medial and the 12th rib is lateral. Now we'll continue to use these anatomical directional terms throughout the entire course. But for now, we've got a good foundation for moving on to further discuss the skeleton.